Okay, in this video, we're going to talk a little bit about infection, particularly as it relates to multi-drug resistant organisms. And this is something that is out there. It's pretty prevalent. And infection, we've been talking a lot about in society just because of COVID-19. Uh, and so I hope that as individuals who are in a program of health, that you've been utilizing the situation around us to kind of incorporate how um, infection and transmission and all of those things that we're seeing in the news and in our daily lives kind of come back to what we're learning about here in our nursing program, or perhaps what you already know about. I don't remember if they talk about infection and transmission and things like micro or anatomy or whatever, but uh, you should be able to kind of start to see a connection between what we're actually talking about in class here with what you're seeing in the world. So we're not really going to talk about COVID-19 during our infection lecture, but some of these things, terms that you see or things like that might get you thinking about some stuff that you've been learning about in life and hearing about. So, an infection is really an invasion of the body by some type of pathogenic something or another that essentially is trying to survive, right? And for it to survive, it needs to create numbers or and it needs to build up its numbers, and the greater the number, the greater the survival rate for this pathogen, right? And in order for it to do that, depending on what type of pathogen it is, whether it's a bacteria or a virus or a fungus or whatever it is, in order for that pathogen to survive, it's going to have to cause damage to the host, which would be us, right? And it does that when it does start to reproduce, when it does start to multiply. Disease in the human body results because of cellular injury from the reproduction of this pathogen, or because this pathogen might secrete a toxin or something of that nature. So it's kind of this back and forth between one organism trying to survive against another organism trying to survive, being the other organism being us. So as I mentioned, there are multiple different things that can cause actual infection in the human body. We always think of things like bacteria and viruses, but there are other agents that can lead to infection. So, lists that you see here: protozoa, helminths, that's like parasites, fungi, whatever the case may be. So remember that infection is because of some type of cellular destruction. And remember how the immune system responds to cellular injury, right? It sends out the armies. We start to see increase in flow of blood, flow of fluid, white blood cells of various different sorts rushing to that area, not only to attack whatever it is that's causing that cellular destruction, but also to clean up, the debris that is left over afterwards. Let's see. So just trying to bring it back to kind of what we have talked about with what we've learned about the immune system. So unlike how the immune system can attack itself, like we attack, quote unquote attack, whether it be like an autoimmune disease process or like inflammation, right, being part of the immune system, that could potentially cause problems. Now with a pathogen, bacteria or virus or whatever the case may be, we have something else that is causing cellular destruction within the body. So Every pathogen has a path that it follows in terms of how it causes disease. During that incubation period, that's the time from when that organism enters the body until we start to see clinical signs and symptoms, and that can vary considerably depending on the organism. Um, the organism essentially has to reproduce enough until there are sufficient numbers in the body that are going to cause adverse effects to the host. So, like when we talked about, or when we talk about or hear about um, COVID-19, that incubation period is, what are they saying, like 7 to 14 days? That's why they're having people isolate or self quarantine for 2 weeks, right? Because that's the amount of time that that they're seeing, average amount of time that they're seeing that it takes for symptoms to start to appear. Now, the prodromal period is when we start to feel like something is wrong. We may not be feeling horrible, but we start to feel like just not right. Okay, we may have some mild symptoms. Maybe we have some swollen lymph nodes, or maybe we have a scratch in our throat, or maybe we just feel a little bit more tired than normal, just don't have that same energy period. Perhaps we lose a sense of smell or sense of taste. Just depends on the organism that we're dealing with. The acute period then is when that infectious disease fully develops. So clinical manifestations start to reach a peak here. And that again is going to be dependent not only upon the pathogen, but also the area of the body that the pathogen is infecting. So if we have a pathogen that infects the sinuses, we may have increased sinus symptoms. If we have a pathogen that is affecting the inner ear, we would have those types of symptoms, and so on and so forth. But this is when you really are not feeling very well, and you know without a doubt that you are sick. So the length of this acute period is going to depend on both the pathogen as well as the host's ability to resist and fight off that infection. So again, if we kind of bring that back to what we're learning in the world about COVID-19, this acute period can vary greatly among individuals. Some people, may be lethargic, have a headache, have a bit of a cough, some shortness of breath, and convalesce at home, right? Convalesce mean recover at home. Whereas others, they really have loss of lung function, and they end up in acute respiratory distress syndrome, or ARDS, right? And respiratory failure. So it can just depend on the host resistance. This is why individuals who have those risk factors, that we're seeing a correlation between the severity of the illness with some of the known historical disease processes that people have, why we're encouraging those individuals to quarantine and take extra safety precautions, like individuals with COPD or hypertension over the age of, I don't know, whatever it is, 60, because the data correlates with those people in those groups have an increased incidence of developing more severe disease, right? And then the recovery period, this is when signs start to get better. Those clinical manifestations start to subside. And again, that can be different depending on the resistance and health of the host, as well as how the pathogen that is affecting the individual. So with the COVID-19, that convalescent period could be very quick, or it could be very extensive. It just depends on how much damage has occurred because of the cellular destruction that the pathogen has caused. A little bit about transmission, and this is about how different pathogens are spread from one host to another host. And this is, first of all, we use what's called standard precautions for all individuals, regardless of whether they have a known infection of a pathogen. So standard precautions would be you use whatever you think you need based upon what you know you're going to come in contact with. So for example, if you walk into a room, you open the door, and there is stool all over the floor, you might wear, and all over the bed and all over the patient, you might wear a gown and gloves and shoe covers, right? If you walk into a patient's room, and they've been incontinent of urine, you might just wear gloves. If you go into a patient's room and they have a lot of coughing going on, perhaps you choose to wear a mask, right? So standard precautions is really the way that we choose to utilize personal protective equipment based upon what we think we're getting into. I hope that kind of makes sense. So that's the first type of precautions, standard precautions. We can use that with anybody. No one has to tell us, in other words, they shouldn't have to tell us what type of PPE to put on. Now, transmission-based precautions, that's the other category of precautions that we utilize. Transmission-based precautions are going to be based upon the way in which we know a pathogen is transmitted. Okay, so for example, we can have airborne precautions. That means that we know that a pathogen is spread through the air, suspended in very small droplets, and can stay in the air for a long period of time. The particles are very small and aerosolized, and so they stay there suspended, and we have to use particular type of personal protective equipment so that we don't then breathe those particles in. An example of that would be something like tuberculosis. Let's see, SARS was another one. MERS was those two are both coronaviruses. COVID-19. If the patient is receiving what we call aerosolized treatment, meaning they're on a BiPAP or CPAP or a ventilator, nebulized treatments, things like that, is going to cause those respiratory secretions to aerosolize into smaller particles that stay suspended in the air. And so we wear special respirators, whether that be an N95 mask that's very tightly woven, that can withstand those smaller particles, or something like a PAPR that is going to kind of like filter out the air while you're breathing and to protect you from that. So these individuals are also going to be in a negative pressure isolation room where the air kind of pushes out away from the room. So it's not pushing out of the room into the hallways. It's kind of sucking it out through the ventilation system, so to speak, I guess. Droplet precautions are also passed through the air, through normal talking, coughing, sneezing. Droplet precautions, the bacteria or the virus or whatever the case may be, is suspended in larger droplets. And those droplets are heavy and they fall to the ground quickly, typically within 3 to 6 feet. And so a simple face mask is typically appropriate, as is appropriate distance. So if you have a patient who's lying in a bed and you step into their doorway, not into their room, but into their doorway, you're not going to be at risk for contracting that, because of the distance between the doorway to the bed is greater than what those droplets would stay suspended in the air. As opposed to an airborne precaution, where those droplets can travel much further, they're lighter, they stay suspended in the air, and so we would keep a door closed and not really stand in the doorway. Okay. Droplet precautions truly is what is being recommended right now for COVID-19 for the general population when being out and about, wearing a simple face mask and maintaining social distancing. That's an evidence of droplet precautions, because those types of droplets are big enough that they're going to fall to the ground rather quickly. So that's why those things are affected. And I'll just leave it at that. Okay, next one up is going to be contact precautions. We do have a bit of a subset of contact precautions, and contact can be either direct or indirect. So with contact precautions, that's where you touch me, I have the pathogen, and then you touch yourself and it enters the body. That could be through mucous membranes such as the eyeballs or the oral mucous membranes, or it could be uh, oral into the digestive system where you swallow that pathogen or whatever. Or it could be indirect contact. That would be where you touch a surface that is contaminated by a pathogen, and then you touch your eyes or your nose or your mouth or whatever. So again, these are all concepts that we're hearing in the world that we're living in today, where with recommended precautions, cleaning of things, not touching your eyes, nose, mouth, that kind of thing, because these are ways in which we know pathogens are transmitted. Now, enteric precautions is a subset of contact precautions and refers to pathogens that are spread in the stool or fecal matter. Most commonly, we see this with Cdiff. That is an enteric precaution pathogen. And the enteric precaution, the thing that's special about it is you must use soap and water for hand hygiene, because the alcohol-based hand sanitizers do not kill the pathogen. You actually have to physically wash the hands with soap and water to get rid of that. So enteric precautions is contact precautions. It's just a subset of that. Okay, so we've talked a little bit about what happens with infection. We've talked like the stages of infection. We've talked about transmission of infection. We've talked about what infection is. So now we're going to kind of break down the different categories, so to speak, of infection. So acute infection is typically what we think of when we're talking about some type of infection. You have severe ear pain, you go to the doctor and they say that you have an ear infection, you have these acute symptoms, that's an acute infection. You have strep throat, you have these symptoms, that's an acute infection. You have, pneumonia, you have an acute infection, right? So that's typically what we think of when we talk about an acute infection. When we talk about a chronic infection, this is when we have an infection that for some reason or another, the organisms were not completely eradicated from the body, and there are some that still remain. And so the clinical symptoms might be mild, but you just never really seemed to get better. We start to have episodes of acute infection within this drama of chronic infection. We can see this often with some infections like osteomyelitis, which we'll talk about in a few weeks. Patient has this bone infection and they just have the infection for a long time. It's almost like, I don't want to say that the body just kind of gets used to it, but it kind of is like that. It's just there's a low enough level of pathogen in the body that it's not making you super sick. Your body's kind of handling it, but it's just not handling it enough that it's going to get rid of it. Now, septicemia or sepsis, this is a buzzword. We hear this all the time. This is an overwhelming systemic infection. And when we look at infection, we really need to think of it as something that's on a spectrum. With our little acute infections that we get, that we, perhaps go to the doctor for, we're here on this low end of the spectrum of sepsis, but we can be all the way along that spectrum up to where we get into what's called septic shock. And we're not going to really talk about septic shock. We'll save that for complex med surg, but I just want you to understand how infection can get worse and lead to overwhelming systemic infection, and that's what sepsis is. This is when infection starts to circulate and reproduce in the blood, and it can affect all of the systems within the body. And so you're going to start seeing more systemic decline among multiple systems. So you might see cardiovascular changes, you might see renal changes. The signs of the infection are going to get worse. If a patient has, for example, strep throat, we typically think of a sore throat and difficulty swallowing, I mean, I guess some people have nausea and vomiting and stuff like that with strep throat, and if it's left untreated, it could start to spread that bacteria through the bloodstream. It could lead to distal site infections where we have like an endocarditis. Maybe that infection kind of starts to grow on a heart valve, or it could just be circulating through the blood and wreaking havoc. Our blood circulates through all the organs, so we can have changes in blood pressure and all of that kind of thing. So let's see, tachycardia, tachypnea, mentation, breathing problems, high or even low temperatures, high or even low white blood cell count. At a certain point, they kind of start to poop out and start to fail. So that's really what sepsis is. And at the top end of that spectrum of sepsis then is septic shock, where we start to experience those shocky type symptoms of circulatory collapse. So we can fall along anywhere along that line. Hopefully we catch a person at the very early stages of an infection so that we can treat it and get rid of it, but sometimes that just doesn't happen. Signs and symptoms of infection are going to vary depending on the location that an infection is taking place. So how do we know that our patient has an infection? Well, if they have pneumonia, they're probably going to have things like cough or sneezing or dyspnea, right? If they have Cdiff, they're going to have things like diarrhea and abdominal pain. So it can be very system specific. We can have local signs of infection. Sometimes if it's an external tissue that is infected, we could see it, like inflammation or swelling or redness or warmth or something like that, such as with an incisional infection or maybe a skin infection. However, we also see signs of inflammation and swelling in internal organs because a patient might have pain or tenderness. We might visibly be able to see that an organ is swollen. We're able to palpate a particular organ. So just because we can't see the inflammation doesn't mean that it's not there. If I have lungs that are inflamed, they're going to be more difficult to ventilate, right, to open up. If I have a gallbladder that's inflamed, it's going to be more tender and painful. If I have a liver that's inflamed, again, more tender, painful. That kind of thing. Let's see, swollen lymph nodes, that could be a sign that infection is taking place. Other general systemic signs, these are not specific to any one particular infection. Many of you may have experienced some of these things like fever, weakness, headache, nausea. These are not going to point to any one particular infected location. They're just more of a general systemic sign of infection. If infection becomes very severe, we can have central nervous system involvement, such as confusion, seizures, or even loss of consciousness. Okay, let's talk about a few multi-drug resistant organisms. We just have a couple, I think 2 or 3 here that we're going to talk about, but let's go ahead and get into that. First of all, in order for us to be able to identify that a patient has a multi-drug organism, we have to detect it. And in order to do that, we have to get some type of sample for us to know that the multi-drug resistant organism is there. So the difference between a multi-drug resistant organism and a regular organism is it's still an organism. It's still a bacteria is typically what we're talking about, or a virus or whatever. But it's resistant to specific antibiotics. So normal conventional antibiotics perhaps are not working anymore, and so we have to utilize kind of stronger antibiotics, so to speak, to be able to manage these pathogens. So if we have to detect it, and the way we're going to do that is we're going to get some type of sample. So if a patient has diarrhea, we're going to get a stool sample. That's how we know they have MRSA. If a patient has a lot of drainage out of a wound, we would get a wound sample, a wound culture. And we could see that maybe they have MRSA in that wound, and then we could treat it. If a patient has recurrent urinary tract infections, perhaps we'll get a urinary sample so that we can see if they have some kind of resistant organism that's causing their recurrence of urinary tract infection. So we have to start with a culture. Another thing that we do sometimes in hospitals in an effort to contain outbreaks of some of these multi-drug resistant organisms is implement what we call surveillance programs. A recent study suggested that lower rates of MRSA were found in healthcare settings where surveillance programs for these organisms were being implemented. And a surveillance program really is all about looking at a particular high-risk population, say, for example, critical care patients, where a facility has been having an increased incidence of, let's say, MRSA pneumonia, and they start just detecting or looking for patients who might be colonized with a bacteria. And so what they used to do where I worked is every patient that would come into critical care would get a nasal swab sent down to detect for colonization of MRSA. Now, colonization is different than infection because colonization just hangs out. It doesn't cause any kind of disease or cellular destruction. It's just living their mind in its own business. But it has the potential to cause disease or destruction. And when we have a high-risk population of individuals, such as critical care patients, who have a decreased immune system because of their critical illness, and multiple portals of entry, such as ventilators, central lines, urinary catheters, all of these things that are invading the body unnaturally, but helping the patient during this critical illness, they are at increased risk from this potential that this organism that's just been hanging out can do. So with the surveillance program, we would send that nasal swab down, check for colonization, and then if they were colonized with MRSA, to prevent an actual infection, they would be treated for that and be decolonized with something called Bactroban, or mupirocin is an ointment that would go in the nasal in the nares twice a day for 5 days, and then they would be decolonized, and it would decrease the incidence of like a MRSA pneumonia from ventilator or a wound infection or whatever the case may be. At a certain point where I work, it was determined that most patients who came into the critical care unit were indeed colonized with MRSA. And so it got to the point where instead of testing for colonization, they just treated for colonization. And so now people that come into the critical care unit will be placed on Bactroban ointment twice a day for 5 days. It takes out the delay of the results to come back from that testing. So we automatically decolonize patients who come into the critical care unit. Hand hygiene is one of the best ways in which we can manage the spread of multi-drug resistant organisms. It really begins with prevention. A lot of declining rates of these infections have been attributed to the use of alcohol-based hand rubs and improved hand hygiene programs. When I first started working in nursing 15 years or so, we didn't have hand sanitizer. I don't feel like I've been around for that long, but I do remember not having hand sanitizer, and I can't recall when I actually started seeing hand sanitizer. Now that I think about it, yeah, I can't even remember when I started seeing it. It was all just hand washing with soap and water. So that has been a wonderful advancement in reducing the spread of multi-drug resistant organisms. And then we isolate our patients who have been identified with having these. So patients who are in the healthcare system either colonized or infected with some of these organisms are placed on some type of isolation appropriate to the way in which that organism spreads, and that helps reduce the spread from patient to patient within that hospital. Healthcare workers' hands are one of the number one reasons how these infection outbreaks can occur. We can utilize whatever PPE is appropriate for the way in which that pathogen spreads, and then also proper hand hygiene before entering the patient's space as well as exiting the patient's space. So these are ways in which we can manage the spread of multi-drug resistant organism. So I do want to talk here about MRSA. That stands for methicillin-resistant Staphylococcus aureus. And Staphylococcus aureus is actually a common asymptomatic pathogen that lives on our skin, and it's actually considered normal bacterial flora in humans. So it can live on bodies or surfaces for days or even weeks. It's spread via contact. If it's living on the skin or whatever, either by direct or indirect contact. The thing about MRSA is that it is resistant to methicillin, which is a type of penicillin type antibiotics, and so we have to use a different type of antibiotic to be able to get rid of it. The other thing about MRSA is because it is a staph, if it starts to get mingled with the non-resistant staph, it can kind of share its properties with those non-resistant staph and then make those non-resistant staph resistant. So it really is kind of a big deal. And the other interesting thing about MRSA is it can infect so many different body systems. So not only can we have a skin infection with MRSA, but it's quite versatile. It can live in wounds, it can live in urine, it can live in the lungs, it can live in the blood. So here we have this one single pathogen that is versatile and can multiply and grow in a variety of different spaces, both aerobic and anaerobic spaces, and it can communicate with non-resistant brethren and make them resistant. So it is kind of really a big deal. We do have what's called community acquired and hospital acquired. Now, they're two different strains, so to speak. Of course, hospital acquired is going to be more virulent and more difficult to manage and get rid of, as opposed to community acquired. The risks for each of those, of course, are going to be different as well. Community acquired MRSA is going to have risk anytime you have a close living quarters or close inhabitants, I guess, of groups of people, you're going to have a higher incidence of community-acquired MRSA. So military barracks, college dorm rooms, daycares, prison systems, sports locker rooms, different things like that, where you have lots of people utilizing the same space and facilities. We're going to have an increased incidence of community-acquired MRSA. With your hospital-acquired MRSA, it's going to be more those types of people who have an altered immune system, maybe who are on antibiotics, who have had invasive procedures recently, things like that, just in nature of being in the hospital as well. Now, the clinical manifestations of MRSA are going to depend on the site that this pathogen is actually growing. So if it's in the lungs, it's going to be signs and symptoms of a pneumonia. If it's on the skin, you're going to have signs and symptoms of a wound infection. So I'm not going to go into every site that a patient can have MRSA and talk about the clinical manifestations. Use your imagination there. And the way that we're going to treat MRSA is typically with vancomycin. This antibiotic is very hard on the kidneys, so we do have to watch renal function in our patient. And now when I'm talking about treatment right now in this moment, I'm talking about like a hospital-acquired MRSA or a more severe infection related to MRSA. We're going to use vancomycin. So as I was saying, difficult on the kidneys. We have to watch renal function, things like BUN and creatinine. We also want to make sure that we're giving the patient a therapeutic dose of vancomycin. And so we will be drawing drug levels on these patients to make sure that it's therapeutic and that it's not at a toxic level. So if it becomes too high, we may have to adjust the dose of vancomycin. Our pharmacists are really helpful with dose adjustments of vancomycin, so they may look at those particular levels. IV vancomycin can cause phlebitis. If it extravasates into the tissue around the IV site, it can cause tissue damage. There is a particular antidote, and I can't remember what it's called. I think it's hyaluronase, but don't quote me on that. That we have to inject into this site to prevent further tissue damage. So when we're giving this through an IV, we need to make sure that we're monitoring the IV site. Another interesting thing that that IV vancomycin can cause is something called red man syndrome. If we infuse the medication too fast, the patient can have this kind of systemic peripheral vasodilation, and they can get really red and hot. I think it can even cause a bit of a drop in blood pressure, so we want to make sure that we're not infusing our vancomycin too quickly, no faster than an hour. Most of it I've ever given has been over a couple of hours. Let's see, I already mentioned mupirocin or Bactroban in the treatment of colonization. Let's see what else I want to tell you about the MRSA. I think that's pretty much it. It's a nasty little guy, and primarily because it, like I said, it can communicate to non-brethren and make them brethren, and it can cause infection in so many different places. Let's see, here are a few other multi-drug resistant organisms that your book talks about. I'm not going to really go into these a whole lot, but I do want to just mention them. VRE stands for vancomycin resistant enterococcus. This bacteria, enterococcus, typically lives in the intestinal tract, but it can cause post-operative wound infections as well as urinary tract infections. Risks for VRE include prolonged hospital stay, very severe illness, recent abdominal surgery, administration of enteral nutrition, and immunosuppression. And this is typically a contact isolate. Now that might depend on whatever facility that you are working in. Some facilities like IU Health here in Bloomington utilize a term called isolation 2.0, and for pathogens such as MRSA and VRE, we don't utilize full like a specific contact precaution or droplet precaution depending on the location of the MRSA, but we utilize whatever PPE we're going to need in regards to whatever we're dealing with. So it goes back to that standard precautions for our VRE and MRSA patients. And one of the reasons that IU Health Bloomington decided to implement that isolation, it is evidence-based, so don't think they only did it because of COVID, but that is definitely what prompted it in the conservation of and responsible use of personal protective equipment. There are lots of other facilities prior to COVID that were implementing what we call isolation 2.0, but just know that with that protocol, we'll call it, you have to know the location of the pathogen and what kind of disease it's or infection it is causing, so that you can appropriately utilize the PPE that you need to care for that patient. CRE stands for carbapenem resistant enterobacter. I don't know if I said that right. This is a pretty nasty little bug. It is resistant to pretty much every antibiotic that we have. The carbapenems is a group of antibiotics that were our last resort antibiotics, and now these have become resistant to that class of antibiotics. So it's very difficult to treat. Something that is spread by contact. Depending on where you're at, Your isolation might look a little bit different, but when I have worked, these patients have been one-to-one nursing care and have required full contact PPE. We're not worried about airborne with CRE, but we are worried about transferring this bacteria to any other people because we don't have the antibiotics to treat it. And so gown, gloves, booties, hat. You may wear a mask. I can't remember. It's been a while. Maybe not. I can't recall. But anyway, the whole goal is to not give this to any other person because we just don't have the antibiotics treatment. We know it exists. People are working on it. There are antibiotics. They're very expensive, and we don't want resistance to occur, which kind of brings me back here for a moment. We can pause and talk about how resistance actually occurs, right? Number one, nursing needs to really educate patients about completion of antibiotics, because partially that is how resistance occurs. When patients don't complete a course of antibiotics, that allows these bacteria to not only develop essentially defense mechanisms against the antibiotic, but also which leads to resistance, but also they don't kill it completely, and so then it can build up again, and then those ones that are building up again have learned how to mutate and defend against the antibiotics, so then they become resistant. Overprescription of antibiotics for inappropriate reasons, such as people wanting antibiotics for a viral infection. Antibiotics don't work on viruses. Part of the reason is viruses are actually these little parasites that invade the host cell, and then they replicate and utilize the mitochondrial workings of the human cell to replicate as energy sources, and replicate until they essentially burst the human cell, have cellular destruction, and then all of these little virus particles float out into the body and are then able to invade more cells. And so in order for us to get to these viral entities, we have to be able to enter the human cell, and we don't want to hurt the human cell. So antibiotics aren't going to work against them. They have different types of membranes and mechanisms of reproduction. So that's another thing that contributes to resistance. Okay, back on track. VRSA, that stands for vancomycin-resistant Staphylococcus aureus, which is not a good thing because we've already talked about MRSA and how we treat it being with vancomycin. And if now we have something that's resistant to vancomycin, we have this horrible superinfection. Okay, I do want to talk about Cdiff. Your book doesn't actually classify it as a multidrug and resistant organism, but we are going to talk about it. It is one of the most common causes of antibiotic-associated diarrhea. In the United States, it's responsible for between 15 and 25% of all cases of diarrhea. It was first detected way back when in 1978 due to the increased use of antibiotics. So there you have it. What happens is when we utilize antibiotics, they kill bacteria, and not all bacteria are bad. When we use an antibiotic, we want to use the best antibiotic for the type of pathogen or bacteria that we're trying to target, but no drug is perfect, meaning that it's going to cause other things to happen, and it's not singularly specific. So while I may be giving an antibiotic to treat a staph infection, it's also going to kill other bacteria that are good. And in our gut, we have good bacteria. Cdiff is a bacteria that doesn't naturally populate us, but if it does get introduced into our gut, into our system, so a fecal-oral contamination, and all of those good, healthy bacteria are depleted because of antibiotics, right? Like broad spectrum antibiotic. It kills those good bacteria in the gut. Then C. diff can take over and cause a horrible gut infection. C. diff is a spore-forming anaerobic bacillus. It's resistant to many types of disinfectants. It's resistant to heat, it's resistant to dryness, so it definitely has staying power, and they can live on surfaces for months. They can live in skin folds, on the hands of healthcare workers, and so they're very easily transmitted. Patients who have C. diff are going to have diarrhea, severe diarrhea, abdominal cramping, leukocytosis. There's usually a very distinct and foul odor associated with C. diff. You can often smell it. Every now and then I've been wrong. It typically has a particular kind of like mucusy-like consistency to the stool. So before you can treat C. diff, you have to make sure that that what we're dealing with is actually C. diff. So we want to get a stool culture, right? We have to have a stool culture to detect C. diff, and then we can give a medication called metronidazole, also known as Flagyl. It's typically our first antibiotic that we're going to use for the first occurrence, hopefully only occurrence, of C. diff. If a patient has recurrent C. diff, in spite of taking Flagyl, or it just won't go away, they might be started on an oral vancomycin. Oral vancomycin kills the bacteria at the site, and it is the first choice for severe infection. Difficid is a newer medication that's reserved for recurrent infections. I've only seen it used a couple of times. And then fecal transplant is relatively new. It's been used more and more in the last few years. It's showing a high success rate, and it's used for those individuals who have had C. diff infections at least 3 times or more, or if they still have an infection after a 6 to 8 week course of oral vancomycin. So this is for really severe infections. And fecal transplant is exactly what it sounds like. They have fecal donations that they process and purify, and they will transplant this into the colon of a patient who has this recurrent or resistant C. diff infection, and they'll do that via a colonoscopy. Probiotics are another treatment that we can use to help prevent C. diff. Probiotics have reduced the incidence of simple antibiotic-associated diarrhea. Sometimes we can utilize them to help treat recurrent C. diff. Efficacy of probiotics is inconsistent, but if you know that somebody is on an antibiotic and their stools are starting to loosen up, which is going to happen because we're getting rid of all of the bacteria in the gut, we can ask the provider to prescribe a probiotic to help prevent C. diff. Also, nursing needs to make sure that you're using good hand hygiene between patients, using appropriate PPE if you are caring for a C. diff patient, so that you're not giving it to someone else in the hospital. Because C. diff can cause severe diarrhea, we're looking at potential for electrolyte abnormalities. We also are concerned about fluid volume deficit, as well as weakness, all that stuff that goes along with hypovolemia, so weakness, orthostatic hypotension. These patients are going to have potentially severe urgency. When you gotta go. So they can be at high risk for falling. If they can't make it to the bathroom, perhaps a bedside commode would be a good idea so they don't have to go quite as far. We want to be careful not to use incontinent briefs on these individuals, and if we do, we need to perform hygiene or teach our patients to perform hygiene routinely, because if we have someone who's incontinent of stool and then their stool sits in, an incontinent brief, like a pull-up, that then leads to a potential for urinary tract infection. So we want to be careful not to promote that. Skin excoriation is another potential problem for patients who have C. diff because they're losing a lot of stool. They may be having incontinent episodes, and that stool can sit up against the skin and cause contact-associated dermatitis, pain, inflammation. And so we can utilize protective barrier ointments or things like that to help protect the skin from the stool. Let's see. Anything else I want to talk about with C. diff? I think I've covered everything with C. diff. And I want to say, just lastly here, just to close us out, I do want to kind of, because I know everybody will ask about it, and I've kind of hinted on a lot of this stuff as we've gone along about COVID. Officially, it's SARS-CoV-2 is the official name of this particular coronavirus. It is a coronavirus, just like a lot of other coronaviruses, such as SARS and MERS and influenza and what other coronaviruses are out there? I don't remember. But it is a coronavirus, and really all that means is it's what the virus looks like when they look under a microscope. They all look very similar to that. It is unique, though. It does have its own properties of transmission and infection, as well as treatment. It's spread via droplets, as well as through contact, even indirect contact. And so this drives the way in which we utilize personal protective equipment and social distancing. This is dictating how we're implementing these types of precautions and cleaning practices. So this is why you wear a mask when you're out in public, you maintain social distancing, and places are increasing the frequency in which they clean surfaces in which this virus can live. If a patient is on some type of aerosolizing producing treatment, then we know that it can be an airborne spread as well, but that doesn't typically happen in the general population out in the community, although coughing can cause that. So coughing causes aerosolization of droplets. So you do want to be careful with coughing. Transmission of this virus can occur sometime during the prodromal phase, and that's before you start to show symptoms, and it can also occur after symptoms already appear. This is the theory behind why we're encouraged to be careful, because even if we are asymptomatic, we can still spread the infection. Its spread is shown to be linked to proximity of someone with the virus, as well as the duration in which we are around that person with the virus. So all of these, and this is not stuff I made up, just so you know. This is not stuff that I got off of the news or that anybody told me. I did use a resource called Up to Date, is a professional medical resource, evidence-based, based on current research and all of that. So these are things that are based on current research and evidence. So again, this is nothing that I made up or that I'm politically leaning towards or anything like that. I'm just presenting what the research is showing and how that research drives our cleaning procedures, what personal protective equipment we are recommended to wear, how we distance ourselves from others, that kind of thing. Because it really goes back to a lot of the other pathogens that we've talked about. When we know those components, it helps us to provide protective care to our patients and to other patients. Let's see, what else did I learn about SARS-CoV-2? Antibodies are present, and there is data emerging regarding how well these antibodies protect against subsequent infection. and for how long that immunity is actually present. Because this virus is new, that's why they call it the novel coronavirus, because it's a new coronavirus. Because this virus is new, we don't know a lot about it, and that's why recommendations are continuously being changed, because we're learning more and more about it, and so that's why things are being changed there. Um, let's see. I think that's it. I mean, I just wanted to throw some of those things out there because it kind of correlates to the way that we talked about transmission and infection and treatment and uh, precautions, isolation precautions, and all of those different kinds of things. So I believe, if I recall correctly, you do have an assignment or two associated with infection that you will want to make sure that you complete. As always, if you have any questions or any concerns, need anything cleared up, please do not hesitate to reach out, and I will do my best to clarify those things for you.